And now I'd like to officially welcome you to our second installment of the webinar series entitled Medicare's New Conditions of Participation, Are You in Compliance? Today's session will focus on care planning and coordination of services, and it's my pleasure to introduce our speaker. Sharon Litwin is founder and senior managing partner at 5-Star Consultants. 5-Star Consultants is a national consulting and coding firm specializing in home care and hospice services since 2003. Sharon is a former ACHC and CHAP surveyor, performing Medicare deemed surveys for 10 years. Sharon has been in the home care and hospice industry for over 25 years. In her consulting firm, Sharon assists home care and hospice agencies in providing quality, meeting regulations, ICD-10 coding, OASIS and increasing outcomes and star ratings, and having continued survey readiness. Sharon and her staff perform ICD-10 coding and OASIS reviews, quality, clinical record reviews, mock surveys, and help agencies across the country stay in compliance. Sharon is a regular speaker to education companies, state and national associations, and multiple publications. And with that, Sharon, I'd like to extend a warm welcome to you and turn things over to you.
Patty, I appreciate that. Welcome, everyone, to part 2 of our series on the new home health COPs. Today, well, I think that that's probably the best slide of all the slides you'll see. And you guys, some of you are fortunate enough to be by the beach, and definitely you have to relax. I've had so many panicked calls from agencies across the country. I think I said this before, but they're continuing, that are really feeling out of control with these, not sure about how to implement, not sure what the standards mean, not sure what the surveyors are going to be looking for. And so I think that the key number one thing is continue to provide very high quality of care to your patients and follow the COPs the best that you can. We already have heard from agencies that have just had surveys, and some of the surveyors have been very fair and not completely holding letter to the law or black and white from what we have from the COPs so far, since it's so early, and other surveyors have been very strict with them. And in both cases, easy or strict, there are a lot of deficiencies that we're seeing already. So we are starting to compile those and, so that we can get a handle on what is being seen as far as survey results and citations on these new COPs as we go forward. We still don't have our final interpretive guidelines. Not sure when we will. That notice that they had put out, I think the beginning of January, said that they will be similar to the draft interpretive guidelines. Well, we're hoping that there's more clarification and some more things could be backed off, but we're just not sure. There has been no updates that I have heard on that. So today, obviously, we're going to still talk about the final row responses. I do have a couple of draft interpretive guideline notes in this session that are important as far as the plan of care. We're going to talk about the comprehensive assessment, care planning, coordination of services, and quality of care chapter. That's the big clinical condition. It's certainly a mouthful to say. Skilled services and aid services. Okay, so 48455 is the comprehensive assessment. Not too many changes with this. We have 4 standards: the initial assessment, completion of the comprehensive assessment, contents of the comprehensive assessment, and update. So of course, each patient has to receive a patient-specific comprehensive assessment. If you are separating out the initial assessment and the comprehensive assessment, and completing it over that 5-day window that we have, then both at the initial assessment and comprehensive assessment, you have to make sure that the patient meets the Medicare benefits as far as homebound and skilled need, et cetera. So an RN does have to continue to do the assessments on patients on multidisciplinary cases. So not as we hoped that possibly therapists could do, especially a PT could do an opening if, for instance, it's a total joint replacement and the RN is going in solely for maybe one lab draw, staple removal, et cetera. But that has not changed. So as long as it is an RN on the case, nursing on the case, they have to do the initial assessment, determine the immediate care and support needs, and again, the eligibility. The time frame has not changed. The initial assessment has to be within 48 hours of the referral or within 48 hours of the patient's return home or on the physician's ordered start of care date. As you'll see, I told you, I believe last time, that the COPs are rather fragmented. You see something about a piece one place, then you see it later. Well, with that, the physician ordered start of care date, they did add to the resumption, the ROC, which is very good, because then in case there is a legitimate reason to be after that 48 hours from the patient's return home, which does happen often, then you're not automatically just late and out of compliance, because now you can put a physician-ordered start of care date for ROCs as you do for start of care. When therapy is in as the only service, it's as it is today, is that the therapist then can do the initial assessment and the comprehensive assessment. Now, the OT still is not a qualifying service. I think I have that in a slide coming up. Again, you know, we were hopeful that maybe that would change as well, but that has not. So in essence, it's the same as it is today. I shouldn't say today anymore, huh? It's the same as it was on January 12th. They are not saying that the OT can establish Medicare eligibility, so they can't be that qualifying service to do that. All right. So, did I go by one? Okay. What's in the comprehensive assessment? There are some new things. This number one, although it's new and a lot of agencies are very confused about it, it's very simple because it's the patient's current health, psychosocial, functional, and cognitive status. We already do that. I get a lot of questions saying, well, we already have that in the M items. Well, that's not sufficient. If you, however, have within your comprehensive assessment a section that documents the assessment of these three important areas, which you already should have been doing, then there's nothing new. This, you know, in the final rule responses, it does say they're not requiring a specific cognitive or behavioral assessment. And of course, there's some other information in here. But, you know, the goal at the very bottom is that agencies develop a more complete, person-centered understanding of the patient. So in other words, of course, we are holistic. The COPs are recognizing that. And so that assessment is necessary. Like I said, you all should have been doing that already. I have some more information on the more confusing topics that have info directly from the final rule responses. I will obviously update a lot once we get the final interpretive guidelines. Since those were drafts, I kept the final rule responses in. Okay, number two of what is in the content, this patient strengths, goals, care preferences, including patient's progress towards achievement of goals. I should have bolded that area. by the patient and the measurable outcomes identified by the agency. So this is new, and we've always looked at goals, but we really have to get much better now at saying, okay, we want to set specific measurable outcomes for the patient as the interdisciplinary team. And in doing so, we need to know what the patient's goals are, their care preferences, and then what exactly are the goals and the outcomes that we're going to try to reach. So this has to be a big part of our entire patient admission throughout the home health, several episodes, possibly one episode, that the team is working to improve outcomes, and we're taking into account the patient's care deficit or care preferences. What they are saying is that we've always focused on deficits of the patient that require treatment. Well, of course, that was because we were following the Medicare guidelines. We have to focus on their deficits, because once they reach a point where they've met their goals, then we have to discharge them. That's part of Medicare. But in not changing the eligibility requirements, they're still saying that let's put that patient in a more active role, have them included with the team to improve their outcomes. Now, to do that, you need to know what that patient's set of care preferences are. So the goal is that the agencies plan for and provide care that is both patient-directed and in accordance with the physician-ordered plan of care. Really, absolutely nothing has changed here. I just don't think that we're really documenting well as far as the patient's strengths, goals, care preferences, progress towards goals. That's a real big area that you have to be sure that the disciplines are identifying what the goals are, and throughout the care, what is that progress? And then, of course, you go back to the drawing board if something isn't working, or you see if you can further that goal to improve outcomes. That is pretty much the whole philosophy of our COPs. And notice I keep saying improvement of outcomes. Well, you all are, certainly familiar with that from being in the value-based purchasing pilot. Also, of course, with the star ratings. Our era of home health now is very much, are you improving a patient's outcomes for each individual patient and then for your agency as a whole? The patient's continuing need for home care, well, that's about a year old actually, but it is relatively new, that in the research, you're going to put exactly what their continuing need is. And be careful when you do that, because we read so many records where what's put there is not the primary reason for home health, or is the same when too much has changed or not gotten better. And now we're saying, well, why is there skilled need? So be very specific with that and ensure that it is consistent with the rest of your record, as well as meeting skilled needs. And then, of course, the patient's medical, nursing, rehab, social, and discharge planning needs, and a review of all meds the patient's currently taking in looking for potential adverse effects. So those are not new. The patient's primary caregivers, if any, and other available supports, including we already document willingness and ability to provide care, but the availability and schedules that has to be documented is new. So you're going to want to add that in with your comprehensive assessment information when you're talking about who is going to be the primary caregiver, and you can have more than one. And does their availability and their schedules allow for them to do especially treatments that are coming up? So that has to be documented. This is not a good example that they give, because we don't have a lot of patients where we have to develop a schedule for turning a bedbound patient. That kind of says to me the lack of understanding of the people who are putting the COPs into place. So you always have to take that, into account as some of these that we really are having a tough time clarifying. But of course, we know that most of the surveyors are very familiar with what we do in home health, and so that definitely assists. So I wouldn't use turning a bedbound patient, but I would use IV dosing. Well, that dosing is very specific for a certain time. And if you're just teaching the son how to do this, and then the son works late and is going to miss when the dose is, and, nothing is done about that, for example, another caregiver, a nursing visit, or the doc approves a time change, things like that. So you have to document that. So that, and the same would be dressing changes and many other areas, but those are obviously our two biggest procedures that we do as far as wound care and IVs for what the patient's caregivers will do that we're teaching them. All right, you have to ensure the patient and his or her caregivers receive ongoing education and training provided by the agency. Now, of course, we do that. That's what we do most of the time. But that's a very weak area of documentation. So you do have to ensure that this is well documented. So much of the new COPs is taking what we already do and elevating it a little bit to make it more patient-centered, goal-oriented, outcome-oriented. The challenge is a lot of our documentation over the years cannot withstand scrutiny of surveys and audits. And so now we're saying much more has to be documented specifically than ever before. So that is one of the biggest challenges that I see. And hopefully there are a lot of field staff on this call as well, because a lot of it is what you document. I don't doubt that you're doing a lot of education and training for the patient and the caregivers, because that's 90% of what we do in home health. But you have to write it down specifically, and to have that to be on track with each other, you have to be working with that team that's taking care of Mrs. Jones. This is how I always give the example. I'm the nurse, Bob's the PT, Sally's the OT, Mary's the aide. That team is working jointly together to improve Mrs. Jones's outcomes. So of course, what we train, what we teach, how we work with the caregivers, what our outcomes we're working on, all has to flow. That has to be documented. The patient's representative, if any, you remember from part one a lot about the patient's representative. I'm still getting a lot of questions about that. Well, it's either a legal representative, which hasn't changed, or it's that the patient, Mrs. Jones, selects her son that lives 10 miles away to be her representative. Once she says she wants that representative, you document it here in your comprehensive assessment, and you find out for everything that's going on in home health, does she want the patient's representative, her son, involved? If she declines, you document that you asked and she declined. If she wants it, you may have to reschedule to accommodate that. So that's a big part of it that you want to look at. All right. And then, of course, it has to be combined with OASIS. That has not changed, certainly. The updated comprehensive assessment, that hasn't changed. It's still the last 5 days of every 60 days for research. And, the only time there's a difference is with a transfer, a significant change in condition. That hasn't changed. And, quite honestly, we don't use those a whole lot. And a lot of the reason is because if you have a significant change in condition, well, if they're improving, that typically means that we're going to have goals met and we're going to discharge. But if they have, a decline that's a significant change in condition, that typically means a hospitalization. So that doesn't have to be used a lot. I do see agencies that if therapy is ordered in the middle of an episode for something new, some new change, that they do a follow-up OASIS comprehensive assessment so that they can more fully justify the therapy services starting in the middle. But none of those rules have changed, and including discharge and return to the agency during the same 60-day episode. You want to, be sure that I've been seeing quite a few agencies lately that have a very short length of stay. And if the nation is just under one episode, it's like at 58 and a half days, but you are at 30 days, you really want to take a look at that, because you might be discharging your patients too early. That hurts in so many ways, certainly for the patient, but for your team, it's really hard to improve patients' outcomes if you only have them on for that short of time. So if you're way under the national length of stay, that's something you do want to look at. This is where I told you that, later on they will be addressing the ROC. So it's under update of the comprehensive assessment. And so this is where they added physician-ordered resumption date to the ROC, so that if you do not see the patient within 48 hours, but the physician gave you another date, you put that. So that's very much a help for many agencies that have had a challenge with that. It's certainly not meant to say that's for staffing. And then, of course, at discharge, you have to do the OASIS assessment. And remember that OASIS, the discharge assessment, is the main place where the outcomes come from. I've been doing an awful lot of teaching on that, both on site and in sessions, because when you have poor outcomes, the first thing that you want to look at is your OASIS accuracy and consistency. And is that discharge OASIS assessment done in the same manner that the start of care and ROC is done? Because that is what gives you the outcomes, except if you have transfers, then that would. But, the majority are going to be your discharge OASIS. If those are 10-minute visits, easy visits that you can pack in with a bunch of start of cares during the day for staff, they are certainly not walking through the assessment like you do with the patient on start of care, and that could really skew your outcomes. That just talks about what I said about significant change in condition. All right, this is the big clinical condition, as I call it, since it's a mouthful, 484.60, care planning, coordination of services, and quality of care. So it basically is combining acceptance of patients' plan of care medical supervision, which was also a mouthful, and coordination of care standards. So what we have is 5 standards: plan of care, conformance with physician orders, review and revision of the plan of care, coordination of care, written information to the patient. So, of course, every patient has to have a plan of care. It has to be individualized. There have been so many deficiencies, and now I just saw deficiencies from a survey since January 13th about a plan of care that's not individualized. Be sure that EMRs are wonderful. I very much think you need to be on an EMR in today's era, but you don't want to pull over a ton of things to your interventions and goals that are not individualized to that patient. And we see that all the time. We review so many OASIS and start of cares, ROCs research on a daily basis, and that is a common issue. They also, the plan of care has to identify patient-specific measurable outcomes and goals. So you really have to beef up that part if you have not already. And then it has kept who we can work under. It has not, as you see, added a nurse practitioner. And if the physician refers a patient under a plan of care that can't be completed until after an eval visit, the physician's consulted to approve additions or modifications to the plan. Ensure that you are doing this. I just was at an agency that is very poor on their timeliness of getting their 485s out the door. And so, of course, then it takes a lot longer to have that signed 485 back to you. Well, how are you going to update that physician along the way on everything that you're doing? So if you're late on getting plan of cares out there, what you're going to do is have a lot more telephone orders or interim orders, because you have to be having that documentation along the way, that they are informed of everything that's happening, and not only informed, but approving it. So the individual plan of care has to include the following. Nothing on this page is new. Under what's in it, under Roman numeral 12 is new. The description of the patient's risk for emergency department visits and hospital readmission, and all necessary interventions to address the underlying risk factors. Well, we do the interventions. That's what we're doing, is to try to keep them out of the hospital by doing these interventions. But we don't do a description of a patient's risk for emergency department visits and hospital readmission. So that definitely has to be on your plan of care. They don't say you have to use low, medium, high tiers or any specific tool. A lot of EMRs have added a section on that. If your EMR hasn't done that, or if you are on paper, you will need to do that. Down below, we have the education and training. Once again, patient-specific interventions, education, measurable goals, outcomes, and goals identified by the agency and the patient. Have they said this enough time to you yet to recognize how important measurable outcomes and goals are? Information related to advanced directives. If you noticed in patient rights, there was nothing about advanced directives. Don't think it's gone away. You still need to do as much as you do with advanced directives, and that's certainly very important. And so here is the only place you'll see that mentioned in the COPs. And then, of course, they always add in anything additional. Now, 3, under the plan of care, this really talks about an evolving plan of care, and this is an area that still needs a lot of clarification. Hopefully, that will be within the final interpretive guidelines, as all of the accrediting organizations, many states, many state associations, et cetera, plus NOC have really said this needs to be clarified more. What this says, all patient care orders, including verbal orders, must be recorded in the plan of care. That doesn't sound any different than what we've always been doing, because we've put verbal orders behind a static plan of care. We never can touch that plan of care, right? Only in the times where we recert, rock, etc. And so, no, not even rock, I'm sorry, recert, that every 60 days. That's the only time we touch the 485. And that's how it's always been. And then we have maybe 50 interim orders that go with that. But if you look at that first piece of paper, that 485, it's very out of date. What the final rule is talking about is that this is an evolving document. And so it reflects past orders and current orders. As new orders are given to initiate or discontinue, the plan of care is updated. And that didn't mean specifically just by having a separate verbal order. So what they say is new versions of the plan of care are created as needed to assure that each clinician is working on the most recent plan of care, with older versions being filed away in the clinical record in any manner that meets the needs of the agency. So now how it's fragmented, a few slides down, you're going to see us talking more about what that physician has to sign. The final rule wanted the physician to sign the new version of the plan of care every time it was updated. The draft IG said, no, we're not going to change the timing on the 485 plan of care, and that's the only time you have to have the physician sign it. So they walked this back enough and still leave enough things not clarified that as I've talked to some survey agencies, they've said they're still accepting the verbal order. So you want to be careful in your state with your accrediting body of will the verbal orders as they've always been without changing the plan of care be acceptable? Or are they expecting to see a plan of care 485 that is always updated with every verbal order that you have? This is clear as mud, but although it's talking about this evolving document and how the 485 is always updated and older 485s are put away, so that there are less errors with telephone orders being missed, verbal orders being missed. But because of the lack of clarification to this point, one accrediting organization and one state that I talked to said they're still taking verbal orders as they've always done. Okay, so that's why you have to be on the lookout for clarifications and CMS memos, et cetera, that HCAF and NOC put out, that ACA puts out, and that in our final IGs, that will be important. And then to see what the surveying agencies do. Conformance with physician orders doesn't have a lot of changes. Of course, drug services treatments ordered only ordered as by a physician. You can't put nursing and therapy judgment items in there. Flu and pneumococcal vaccines can be by agency policy and consultation with the physician, and verbal orders can only be accepted by personnel authorized by state laws and your policies. So conformance with doctor's orders on 4 is related to timing all orders. This is another area that's confusing for agencies by all of the questions we get. However, bottom line is, although this talks about timing all physician orders, that when we get back to clinical record, and that's at the end of part 4, so it'll be a while, but you can see in the bottom statement on this slide, this requirement corresponds with clinical record requirements, which requires all entries in the clinical record to be timed. Now, this does not mean everything is time-stamped, for example, of when I document. Maybe I'm documenting my visit at 6 p.m., but I did the visit at 9 a.m. So 9 a.m. has to be there. It can still have that date stamp, of course, for the documentation time, but you have to time everything to the actual time. So that includes orders, but it includes everything. Review and revision, well, that doesn't seem to have changed by the physician responsible for home health plan of care as frequently as needed, but no less frequency than every 60 days. And the agency must promptly alert physicians to the changes in the patient's conditions or needs that suggest outcomes are not being achieved or that the plan of care should be altered. You don't just sit on a pain of 7 that everybody's documenting and that the patient's taking their pain meds and it's a pain of 7. That has to be told to the physician because one of your outcomes should be improving the patient's pain. And then you notify the physician that, well, yeah, they're on this heavy-duty pain med, but their pain is still at 7. Physician notification is a top deficiency and continues to grow as a top deficiency. A lot of times it's that it's not documented, but I do see an awful lot of times that the physicians are not notified when they should be. Early, prompt, frequent physician notification by the team that's talking together as they see beginning symptoms, example of a CHF exacerbation, that has to be notified to the physician. Guess what? It prevents the ER visit or the readmission for a CHF exacerbation. Fantastic for your patient, and guess what? Your outcomes are also going up. All right. So the revised plan of care, look at that third sentence, must have patients progress towards the measurable outcomes and goals identified by the agency and the patient in the plan of care. If you aren't documenting progress to measurable outcomes and goals along the course of the care, and specifically when the plan of care is reviewed and revised, you need to jump on that right away. And then verbal orders have to be authenticated by the physician according to your state laws and agency policies. So this is the revision to the plan of care must be communicated as follows. Any revision to the plan of care due to a change in patient health status must be communicated to the patient, the representative, if any, the caregiver, and the physician responsible for the agency plan of care. So, you know, this was questioned, how often does this plan of care have to be re-signed by the physician? And this is where the draft IGs backed off, because the final rule said all the time, any change. And of course, we knew that there would be 100% non-compliance if we're sending new 485s every day to the home health physician for a Coumadin change. And so the draft IGs, this is where it says interim changes in physician orders and the plan of care do not automatically restart the time frame for the physician review of the plan of care. So that is still not clarified specifically, right? That has to do with, are we accepting verbal orders? Are we putting it onto the 485? If it's a cardiologist writing a Coumadin order and the PCP does the 485, are we then sending the PCP this Coumadin order? Well, this is saying that it doesn't automatically restart the time frame for physician review. So we know we don't have to sign, have a new 485 done for every order and signed. And that's what I said, the agency, accrediting agency and state that I talked to, they are not giving deficiencies at this point if you're still doing the verbal order system we've always done. So stay tuned for this. Many of the EMRs have already updated that every time you put an order in, it can update your 485. So you already are doing it the way it looks like we need to do it. Okay, and there are, you know, we have some clients even that one of our clients said that their EMR is not doing it yet. So you just have to really keep posted on this to make sure that you get clarifications when everyone else does. Revisions to the plan of care has to be communicated to the patient, the representative, the caregiver. All physicians ordering the home health agency plan of care and the patient's primary care practitioner or other healthcare professionals who will be responsible for providing care and services to the patient after discharge from the agency. That's a huge amount of people that you have to communicate, revisions to the plans and revisions for the patient discharge, and document. All right, D is coordination of care. Coordination of care is really a big factor in our new COPs. It is this team, this interdisciplinary team, me, Bob the PT, Sally the OT, Mary the aide. We are taking care of Mrs. Jones. That's where that coordination occurs, and then in conjunction with the physician, and then also with the patient, the representative, and the caregivers. So this team doesn't mean your group of nurses come in once a week for a case conference and then you get a fax, you know, summary report once in a while from your subcontracted therapist. Your aides are out in the field. It doesn't mean that once every couple of weeks, every staff member in your staff that can come to this huge case conference where every patient's talked about. Most everybody doesn't know what's going on because they're not involved, and many of the disciplines taking care of Mrs. Jones aren't there. This means everybody taking care of Mrs. Jones. We're integrating the services so that we can improve outcomes. We identify the specific patient needs, anything especially that affects patient safety and treatment effectiveness, and we all coordinate care. Coordination of care sounds like a no-brainer. It is very weak in our industry. Obviously, the reason is that our patients are all over the place and all of our staff are all over the place, and it is difficult. However, this has been a rising deficiency, and you bet now it will. I already saw it in 3 of 3 agencies' survey reports that the coordination of care was given as a deficiency. We have much more meat behind it now. It's much more important. You really need to have a case management model, a team care model, whatever you call it, that has this team taking care of Mrs. Jones, frequently talking to each other and documenting it. That talking to each other could be solely by EMR in that documentation process, as long as it's not just stuck at the end of a visit note, because I can guarantee you I'm not going to read your visit when I'm going in to make my visit. So you have to look at your EMR or what your system is, where this is documented, that everybody on that Mrs. Jones case can read updates. A lot of the EMRs have very good methods to do so. And so that has to be documented. And that comes down to, you know, the CHF exacerbation. About a month ago, I read a record that, not picking on any discipline, but a PTA, the patient had CHF, the PTA was doing a visit, and the patient had more ankle edema, was much more fatigued while walking, and so the PTA, you know, didn't push her and didn't do as much, and the patient was coughing a lot. Well, that was all documented very well in the PTA's visit note. However, there was no documentation that the PT, the RN, or the physician was notified. That's a classic example of, if the PTA had notified the team taking care of Mrs. Jones, I would have known about that as the nurse, and I would have said, well, I have a visit I was going to do in 2 days, but I'm going to go tomorrow or even today because we don't want her to exacerbate in her CHF. And then I call the physician. Maybe it's as simple as getting an extra dose of Lasix, and Mrs. Jones doesn't go into the ER for a CHF exacerbation. That's what we're looking at, improving our patient outcomes by coordination of care. The agency has to assure communication with all physicians involved in the plan of care and integrate orders from all physicians involved in the plan of care and interventions provided to the patient. So that is to avoid duplicate or contradictory physician orders and to assure all patient needs are being met, whether by the agency or the physician. We would expect the agencies to have appropriate systems and processes in place to both identify and resolve conflicting or duplicative orders. Okay, so a lot's being put on the agency's shoulders again for the physicians, but we have this holistic patient plan of care that has orders from maybe a cardiologist, an orthopod, and the PCP does the 485. Do they know about each other's orders? Does that plan of care signing doc for the home health know about the Coumadin orders from the cardiologist? So we have to integrate all and notify all of them. All right, if you're providing any services under arrangement, all of this applies. You have to have your subcontractors coordinating care just like your disciplines that are employed or on your staff do. It can't be anymore that you say, oh, we just can't get our subcontracted agencies to talk to us, communicate with us, give us documentation. They have to be part of the team. Once again, ensure that patients and caregivers are receiving ongoing education and training to provide a timely discharge. Written information is new, and some of it we've already done for years and have had to. A lot of it agencies haven't done well, though. Visit schedule, including frequency of visits by agency personnel and personnel acting on behalf of the agency. So your contractors as well. You know, way back when our ABN laws started, this was when we were definitely supposed to be doing this. And so we have to be sure that these visit schedules are updated in the patient home, has the frequency of everybody that are coming in, has, what days, who's coming. And again, I already saw a deficiency on this. The patient med schedule, that is not new at all. However, it has always been a big area of deficiency that the med list in the home is not updated to what's in the orders in the clinical record. Any treatments that are going to be administered by personnel or contractors, including therapy services. So when you are doing, a home exercise program, wound care, and teaching that patient, you need to be showing that patient in writing what's being done. And especially when you're teaching them, it has to be step by step. Okay, and then anything else pertinent, that's always a catch-all. And now here we have to give the name and contact information of the home health clinical manager. You'll remember in patient rights, we had to give it the name and contact info for the administrator for any complaints that the patient and caregivers may have. But now we give the agency's clinical manager. So that can be the overall clinical manager, director of patient services, or it can be one of the supervisory clinical managers, but you have to have that name and contact in. So that is the big clinical chapter, and it is a doozy, and there are still some areas that are clear as mud. Hopefully we're going to be getting any clarification soon. And in the meantime, check with your accrediting body or your state and see what they are coming in to look at as well. 4A5.75 is skilled professional services. This is taking 3 conditions in what are now our old COPs. We had skilled nursing, therapy, and social services conditions. This now integrates it into one team. You think they're getting that point across enough by doing this? So this now has just 3 standards: provisions of services by skilled professionals, responsibilities, and supervision of assistance. Skilled professionals who provide services to agency patients directly or under arrangement must participate in coordination of care. It's said again. All right, A just says skilled professional services are authorized, delivered, and supervised only by healthcare professionals who meet appropriate qualifications and who practice according to the agency's policies and procedures. There was a lot of talk about, well, goodness, we're not separating them out to their individual skilled need. And the final rule just again said they want everybody held to the same expectations because they're all working together. So B says what the responsibilities are. Ongoing interdisciplinary assessment of the patient, development and evaluation of the plan of care in partnership with the patient, representative, and caregivers. See, that representative pops up all the time. You have to have very good documentation on that. Providing services that are ordered by the physician as indicated in the plan of care. Patient, caregiver, and family counseling. I feel like probably they threw that in because they felt they had to have something from the social services condition. We all do that. However, counseling is a term usually seen with social services. Preparing clinical notes, communication with all physicians involved in the plan of care and other healthcare practitioners as appropriate related to the current care plan of care, Participation in the agency's CoP program. Big deal. Everybody on your staff and contracted has to be involved in your CoP program, which is fine because CoP is to improve your outcomes. So that's, kind of a no-brainer. And everybody has to participate in agency-sponsored in-service training. So, hey, contractors, here's our in-services as well. Supervision of skilled professional assistance just refers you to other COPs, to supervise the LPN, the, therapy assistance, social service, etc. 484.80 is home health aid services. You know, there's some big areas of confusion that we're hoping to get clarified on this one too, but for the most part, it's pretty straightforward. There's 9 standards. I won't read them because we'll go through them. Some of the key changes are taking action where there's a potential or verified deficiency in aid services. There's now a specific process for that. Aids must be integrated into the patient care team. I'm very happy that they put this into our COPs because too many agencies leave the aid out of so many coordination of care subjects, and actually, you know, the aid will document areas in their notes that ends up not going anywhere or anything being done with it, such as the patient's bottom is red today. Well, gosh, that could be a stage 1 pressure ulcer. And so the thing is that the aides are with the patient for a longer period of time on visits and in a less threatening, intimidating way, because it is so personal and they're not, you know, a nurse and a therapist in and out checking this and this. So the aides can see and be told so many things and so many areas that would revise what your outcomes are and your goals are. So it's very important to integrate them into that team. Notice on my example, Mary the aide is involved with me and Bob and Sally. The aides must recognize and report changes in skin condition. I'll show you this later in a couple of places, but bottom line is if you haven't done an in-service on this, on all your current aides, you need to do it as soon as we get off the phone. And the communication skills, which I have more detail on later too. You have to in-service them because they were not trained and competency in that. And so you can do that in-service on them. Best case is your competency in them as well. So you go out with them on these, but minimally in-service them. Take out this next one, just cross it out, because until the final IGs come out, this may not happen. We were excited that the COP said therapists can now do aid assignment sheets and supervise aides even when nursing is on the case. However, the draft IGs walked that back. So cross that out for now, and we're going to, I leave it on my slide so I can talk about that because that's something we really have to see in the final IGs. And don't change that process. When there's a nurse on the case, make sure they're the one doing assignments and supervising the aides. They finally added CNA as a qualifier for home health aides. And they, in every standard, they're putting about documentation of aid training and competency. So obviously that's a big deal, and it is an area of weakness in our industry. So the qualifications, the new one is the nurse aid training and competency eval as approved by the state and listed in good standing on the nurse state aid registry. Now, I recently taught COPs for all-day on-site seminars in Indiana in 3 cities, and right away they said, nope, in Indiana that doesn't qualify. They have to be on the home health state registry, home health aid state registry. And so what you always want to make sure of, everything that I'm going over here in the COPs are great. You have to follow them. But if your state is stricter, if your accrediting organization is stricter, you're going to be held to the strictest law or standards. So you have to make sure of that. This is not a change, it's just something that over the years I know a lot of agencies do not know. And you can get a deficiency on this and possibly a condition. If there is a qualified home health aide, but for a continuous period of 24 consecutive months, they weren't furnishing services that are talked about as a home health aide does for compensation, they have to redo their entire training program. So that means the aide that had to take time off because of burnout and went to work in retail for 2.5 years. When they come back, they have to go through their entire training again. But it also applies to Mary the aide, who took time off from her aide job that was more than 24 consecutive months to take care of her grandpa and was never paid for that. And now she is not a qualified home health aide. So just make sure that you are aware of that. Now, the content and duration of the home health aide classroom and supervised practical training. This is what's in the training. You may be one that does it as an agency, a qualified training agency. I rarely run into that. Another example in Indiana, each of the 3 cities I went to, there were at least one agency that did this, and that's the first time I have seen that in years. But even if you don't do it, you have to be very well aware of what your aides need to be getting. And so they didn't change the 75 hours. It is a minimum of 16 hours classroom training, must precede a minimum of 16 hours supervised practical training as part of the 75 hours. That is not different. The training program has to have all of the following. The one is new, communication skills, including the ability to read, write, and verbally report clinical information to patients, representatives, and caregivers, as well as to other agency staff. Interesting that they put representatives here as well. And so you have to ensure that new aides that you are hiring have a training program that has done this. And then you're going to competency them on that as well. So this is, along with the skin conditions, one that if you haven't in-service your current aides and then set up competencies to occur on this, you will want to do that right away. The rest here is not new. Obviously, the last one, recognizing emergencies and knowledge of instituting emergency procedures, that's a very big deal with our emergency preparedness plan. Make sure that your aides are aware enough that they can tell me what that emergency preparedness plan is. This is not new, but it does take on a big factor as you're looking at some of the bed, bath, sponge, tub, and shower. This is all stuff that an aide has to be trained in and then later competencied. And the competency, they refer back to these letters: the bed, bath, sponge, tub, and shower, shampooing and sink, tub, and bed, nail and skincare, oral hygiene, toileting, and elimination. What it says now, and hopefully this will change, is that an aide has to be competencied in all of these things before they start on patient care. Well, the challenge with that, when is an aide ever going to be able to be competencied in a tub bath, or maybe shampooing in a sink and tub? Maybe never, maybe for a long time. And if your aides have to be competencied in every one of these, this is a problem. And I know at least one accrediting body is really fighting this, saying, okay, we'll hold these agencies to this now, but this needs to be changed because you will not be able to hit all of the competencies in that time period. Now, they do have to be trained in their training program to all of these, but I'm talking about later when it refers back to this, that to do all of these things is going to be rough prior to working them. The recognizing and reporting changes in skin condition is new. They did take away that it has to go into, pressure ulcer stages, thank goodness, because of course RNs have enough trouble doing that on some of the wounds that we see. Any other tasks the agency may choose to have an aide performed as permitted under state law. Well, this is in the training program, so that's going to go more to your competency. And then the agency is responsible for training home health aides for any skills not covered in the basic checklist. What about a Hoyer lift? I saw a nightmare of a case on a mock survey home visit I was making this year where an aide, this was for hospice, an aide in a SNF was getting a combative, belligerent, demented, contracted patient up in a Hoyer lift. And it was very unsafe. And the only time as a surveyor or as a mock surveyor that you stop a visit is for safety and or something very egregious with infection control, whatever, which is safety as well. As she did that first pump of the Hoyer lift, I stopped her. Interestingly enough, her reasoning for doing this was, well, I didn't think you would want me to get help. Usually I have two of the aides in the SNF helping me, and we take her down the hall to the shower. So, of course, that's training to the aide about safety. But what do you think the first thing I asked for when I went back into that agency the next morning was? The aide competency on this aide, and Hoyer lift was nowhere to be found. So that can be an immediate jeopardy. That is something that is so significant. So your aide competency checklist has to be an ongoing dynamic document. You never want to assign an aide to something that they haven't been competencied in. And of course, the individual may only furnish home health services on behalf of an agency after they've successfully completed a competency eval. This is where they refer back to things. You have to observe an aide's performance with the patient, doing it on a task. So this is, 3 that we just looked at, for example, the recognizing skin condition, the bed bath, sponge tower, and tub bath. So that's where it gets tricky. I thought it was very much semantics, and I wasn't even picking up on that until the states and accrediting organizations were doing training and were saying that, yes, it means all of them. And so that's what's being hopefully going to be changed, but we will see. Be sure you document that you've done the trainings on skin condition and communication. All right. So here again, it talks about the competency has to address all those areas with a patient, but the last part of that is the remaining subject areas can be evaluated through exam, oral exam, or after observation with a patient. So that's all that has to be hit on competencies, but the ones that have to be directly on a patient and the ones that do not. Any agency can offer a competency eval program except, and then they get into the reasons, but the big area that a lot of agencies don't know, if you get a condition level deficiency, I don't mean it's a condition level deficiency in aid services. I mean a condition level deficiency in any of the conditions. You cannot competency your aides for 2 years. I always think that must be a slap on the hand as a little punishment for getting a condition, because why you can't competency your aides for all the other conditions you can get doesn't make a lot of sense. So a lot of agencies think it's just if you get a condition level in aid services, and that is not the case. So if you do get a condition, be sure that you comply with that. The competency eval must be performed by a registered nurse in consultation with other skilled professionals as appropriate. They want everything under an RN. An aide isn't competent in any task that he is evaluated on satisfactory, of course. An aide can't perform a task without direct supervision by an RN after they've received the training in the task for which they were unsatisfactory and completed a subsequent eval. So note that it goes back to an RN. And you have to pass all parts of a competency when you have unsatisfactory rating. And of course, you have to have that documentation. Well, the good and bad news is the in-service training hasn't changed. You still have to do at least 12 hours of in-service training during each 12-month period. In-service training may occur while an aide is furnishing care to a patient. And in-service training must be offered may be offered by any organization, but the training has to be required to be supervised by an RN. So take that into account as you're accepting certificates from your aides. You have to know if that training was supervised by an RN. That may not be always easy. Hopefully, a lot of companies are putting that on there because of this. The qualifications for instructors conducting classroom and supervised practical training. Again, our COPs are very fragmented because it goes back to the classes. You have to have an RN who has 2 years of nursing experience at minimum. 1 year of that has to be in home health. And then under other individuals, under the general supervision of the registered nurse. They believe that RNs with nursing experience in home health should be the principal instructors in basic training of the home health aides, while other individuals can provide instruction to aides. Classroom and practical training are under the general supervision of an RN. So again, you have to know that your training programs that your aides have had comply with that. This is the eligible training and competency eval or organizations. So any agency can do a training and competency program, except you're out of compliance with this section. You have someone who's not a qualified aide. You had an extended or partially extended survey visit because of substandard care. So now that it's extended and probably you're getting condition level deficiencies. They don't say specifically conditions, but it's that extended survey with substandard care equals pretty much conditions. Of course, any other reasons that CMS or the state says you can't. If you get sanctions, if you get immediate jeopardy, that's what number 5 is. And number 5 is sanctions with temporary management. If you've ever had your Medicare payments suspended, if you ever had a Medicare program terminated, if you've had sanctions, and the last one, if you're excluded from participating in federal health care programs or debarred from participating in any programs, so that extends it a lot. So it is your responsibility to know that the organization that's doing your aides training meets all those needs. So it might be time to revisit those areas when you're in your hiring process. Now, the G, home health aide assignments and duties, the final rule and final COPs say home health aides are assigned to a specific patient by a registered nurse or other appropriate skilled professional with written patient care instructions for home health aide prepared by that registered nurse or other appropriate skilled professional, that is PTO, TSLP. So we were excited because we thought, well, it's about time that the therapist can work with the aides when that's a real focus of care rather than the nurse. Or they can, vary during an admission who does that, so that this interdisciplinary team is very involved. But the draft IGs say, however, it is possible that a skilled therapist may identify the need for a home health aide service associated with skilled therapy only. In these cases, the skilled therapist may develop the plan for the aide and perform the supervisory visit. Any concerns identified by the therapist during SUP visits must be communicated to the home health aide clinical manager or supervising nurse. So, like I said at the beginning, don't change your process. Make sure that until we get the clarification on this, you keep it the same, that on multidisciplinary cases, the RN is still doing it. Hopefully, it will be changed. A home health aide provides services that are ordered by the physician, included in the plan of care, permitted to be under state law, and consistent with the home health aide training. That's the new one. But, of course, be sure that you are making sure if your aide is doing anything other than personal care, that is put as an order and in the plan of care. The duties of the home health aide include provision of hands-on personal care, performance of simple procedures as an extension of therapy or nursing, assistance in ambulating or exercise, and assistance in administering medications ordinarily self-administered. The draft IGs make it seem like they should just have taken that one out, because what they've limited this to is extreme. Assistance in administering medications in this requirement means the home health aide may take only a passive role in this activity. This assistance is limited to getting water or fluids for the patient to take their medication. Self-administration of meds means that the patient or patient's caregiver is able to manage all aspects of taking her or his medication, including safe medication storage, removing the correct dose of meds from the container, taking the med at the correct time, and knowing how to contact the pharmacy for refills or other questions. So a lot of you probably have your aide doing many of those tasks in that second paragraph. But the first paragraph says the assistance is limited to getting water or fluids for the patient to take their med. So that is a significant change. And since it's in the draft IGs, if it stays that way in the final IGs, that is what surveyors will be looking for. So you're going to have to make a change in that if you've had your aides doing more. 4, aides must be members of the interdisciplinary team, must report changes in the patient's condition to an RN or appropriate skilled professional, and must complete appropriate records in compliance with the agency's policies and procedures. So that one has an awful lot of meat to it. H is supervision of the home health aides. This is kind of confusing because they jump around. If aid services are provided to a patient receiving skilled nurses and therapy, an RN or appropriate skilled professional familiar with the patient, the patient's plan of care and written patient care instructions must make an on-site visit to the patient's home no less than every 14 days. Aide doesn't have to be present. So keep in mind again here, the draft IGs walk this back. This says the therapist can do it, and so we thought that it was pretty much interchangeable, but don't make that change yet. Now, if an area of concern in aid services is noted by the supervising RN, sorry, my alarm went off saying it's almost time, by the supervising RN or other appropriate skilled professional, the supervising individual must make an on-site visit to the location where the patient is receiving care in order to observe and assess the aide while he or she is performing care. So let's say an OT does an OT soup visit. There's no nurse on the case anymore, and the aide isn't there, but maybe the OT seen hygienic problems when the aide was just there that morning. Well, now the OT is going to go make a visit with the aide there. That can also be the supervising RN who makes the visit with the aide there. You're going to see why they didn't follow this in line. But if the deficiency is seen and verified on the on-site visit with the aide, then the agency has to conduct and the aide must complete a competency eval. So the RN has to take over and do this competency eval. What they're saying is you have to do the full competency eval when you find a deficiency, because if an aide skill is noted to be unsatisfactory because of a deficiency in one skill area, it may indicate a higher likelihood of deficiencies in the aide's other skilled area. So this would open up another whole competency eval on an aide that had a deficiency seen on an on-site visit with them. All right, on every single aide soup visit, you have to have these 6 items. Following patient's plan of care for completing of tasks assigned to an aide by an RN or other appropriate skilled professional. Now, this is such a frequent deficiency in home health, and I never can understand why, because if we're checking this every 14 days at a minimum, Are we not looking at the aid assignment sheet and making sure that it still is up to date for the patient, and then that the aid is complying with it? You have that soup visit every time to check that. And the agencies that do that do not get deficiencies in that aids following the aid care plan. Maintaining an open communication process with the patient, representative, if any, caregivers, and family. Demonstrating competency with assigned tasks. Well, you know, there's a lot of challenges put forth on that one because the aid's not present. But hey, is the patient's hygiene very poor when the aid was just there? Complying with infection prevention and control policies and procedures. Again, that's under dispute because the aid isn't present. How do we check that? So you're going to be talking to the family and the patient. You're seeing, visualizing what's going on, and going from there. Reporting changes in the patient's condition. This is very key. This is a new area, and you have to be checking that this has occurred every time you do a home health aid visit, and you have to document it. And honoring patient rights is a new one as well. So again, all elements need to be accounted for in each and every supervisory visit, or it won't count. If you use aid services under arrangement, the responsibilities are all included and not limited to ensuring overall quality of care by the aides, supervising aid services, ensuring aides who provide services under arrangement have met the training and competency eval requirements. So you have to really check out your aides under your contracted services if you are doing that. I don't see that occurring too much. However, in Florida, I do. So you really want to make sure you are doing your due diligence on that. Individuals furnishing Medicaid personal care aid only services under a Medicaid personal care benefit. If you're doing that, okay, so here is where it does say the individual only needs to demonstrate competency in the services the individual is required to furnish. Well, that's great, but you go back to if you're under the regular Medicare aid services where they want to demonstrate competency in a tub and a shower bath and on and on. So, you know, we're hoping that maybe it comes down to this, or they take off some of the mandatory areas for competency. Today, you very well may not comply, as most agencies don't, because your aides may have never been competencied in doing a tub bath. If a tub bath would ever come up, then you would need to competency them. So it's kind of what we find out. However, the one accrediting body that I know of, I don't know about the other two, and I don't know about the states, are holding the agencies accountable for this. So you do want to look at this. All right, so this is a big session, and you can see there are 3 or 4 areas that really are still clear as mud. Some too strict, others too confusing, others more lenient than we thought. So, you know, we need to take all of this information as informed education and be on the lookout for the final interpretive guidelines and any of the emails that come from HCAP with any kind of breaking news that's down from ACA or NOC, and then as well if you are accredited to really keep a close eye on those. But these are the main, you know, areas that you have to be compliant. I pointed out a lot of the key areas. On the more confusing things, I gave you what I think that you need to do today. The best thing is this is a huge, important condition. So you do want to break it down in little sections and make sure that you are compliant. If you have more than 4 people in your agency, break it down into task forces so that everybody is looking at one standard under this condition and ensuring that you have processes set up to comply, that all of your clinicians and aides have been well trained, that you are having quality indicators in your CoP program that are checking to be sure that you are doing this. Those are the key things you have to do in order to meet the condition of this, big clinical condition. And also we had comprehensive assessment in there. I pretty much tie that together. Not too many changes in that though. But of the 3 agencies that I have seen surveyed since January 13th, 1 got a condition level in this big clinical chapter, and the other 2 got 2 deficiencies each under it. So obviously, we know this is a big one. This is our 485, our charting, our AIDS charting, et cetera, et cetera. So of course, it's a huge condition. So obviously, you need to pay a lot of attention to this one. If you have little things that you can quickly fix in other of the conditions, do that. But this one is going to be one that's going to take more work, as is CoP as we get to that one, if you haven't complied with that yet. Emergency preparedness is huge, but hopefully you're already in compliance with that. Being in Florida, you were ahead of the game, plus you've had since November 15th. But anyhow, it seems like every session we have a really big condition to hit. Last time it was patient rights. This time it's care planning and coordination of services and quality of care. So that ends today's session. And now I will turn it back to Patty, and we can see, I'm not sure if I can see the questions. We can turn it back to Patty to see if anybody had any questions.
Absolutely. We have quite a few questions that have come in, so I'm going to skip the infomercials and go right into questions. So the first question comes from Odell, and I believe it's in relation to aid supervision. And Odell, if it's not, just type me another message. But it's talking about what if there are initial orders for PT and the home health aide, and then within the second week there develops a need for skilled nursing, and the nurse now enters the picture. Who would be responsible for the aid supervision?
Well, this is the one that's gone back and forth that we were so excited about when the COPs came out to say, well, of course, then the therapist can keep doing it. And particularly, it would be what is the focus of care, and it could change throughout the admission. But at this point in time, the draft IGs are talking about that the therapist can only supervise and do the aid assignment when it is a skilled therapy only. So when that nurse enters the picture, to be safe in right now, currently, I would have the nurse do that. I would have the nurse sign off on the aid care plan and probably revise it with new things from what has happened to add nursing, and I would have the nurse do the supervisory visits as long as the nurse is in there. I was very disappointed, as many of us were, with that draft IG, making it stricter and only to skilled nursing. And like I said, we've put an awful lot of comments in, and from our big, organizations, they put comments in. Hopefully that will change, but for today, I would have the nurse do it.
Okay, now the next topic has been asked by multiple attendees, and it's been asked in different ways. So I'm going to try to break it up into chunks for you to respond to, but it talks about the 485 and changes to the 485. So first off, most attendees are wanting to know, with the 485, every time you get a new verbal order, does the 485 need to be updated and sent to the physician for signature, or would it be sufficient to send the verbal order to the physician for signature? And then if you're going to recert the patient, the updated plan of care that you're sending to the physician for recertification would then contain any changes to the plan of care that has been made over that course of time, and then you send that to the physician for signature.
Okay, so the last part of what Patty said, at recert, or ROC or whatever, and again, ROC wouldn't count because we don't do the 485s before January 13th. That's the way we've always done it, is have verbal orders signed in between the 60-day episodes. and then send the updated 485 for the new episode to the physician who's over the 485 and get their signature. When the COPs came out in the final rule with the final responses, they made it very clear in there, and I put their wording in these slides here, that they expect that plan of care to be an evolving document and to be updated all of the time. And then a little later, and you'll see that a couple slides later, they say, and they expect all new iterations of that plan of care to be signed by the physician. So of course, we put in thousands of comments and said, you know, there's no way, because if orders change on wound care 3 times this week because the wound clinic keeps changing them and the cardiologist keeps changing the Coumadin dose when we draw our PTINRs, we would be making a new plan of care every day and signing it to that PCP who did the 485. So the draft interpretive guidelines backed off of that and said, we're not necessarily saying that getting a new order is updating the dates and the time frame to send the 485 to the physician for signature. So we really need the final interpretive guidelines out to put an end to this once and for all, hopefully. If the final interpretive guidelines make it very clear and say, no, keep on going with your verbal orders as we've always done for 40 years, then the final rule response would not be used. But at this point, what they put in that draft interpretive guidelines did not say, and I'll give you an example of what it didn't say, 2 things. 1, do you still make that a dynamic 485? So each time there's a new order, you update that 485 so that if I'm taking care of a patient, what I'm looking at right now today is current, because that's the intent behind what the final rule said. So do I still update the 485, but I don't send it to the 485 signing doc each time there's a new order for signature? Okay, so that's number 1, and that's, you know, what I suspect. Number 2, though, is if you're taking orders from multiple docs and a cardiologist gives you a Coumadin order. Now, that is a new order that the plan of care signing physician doesn't know about. So at that time, do you update the 485, have that Coumadin order added to that, and send it to the plan of care home health 485 signing doc because he was unaware? Remember that one standard that says we have to integrate all the orders and notify all the physicians on the case of any new orders to avoid contradictory or duplicative, especially medications. So those are the questions. Now, I contacted one of the accrediting bodies and said, and one of the states, and said, are you citing if the agencies are still doing it the old way, which is we don't touch the 485, we use verbal orders, and then we update the 485 at, for instance, research, and that's when it's signed. That one accrediting body and that one state said, no, we are not citing for that because it's too unclear at the moment. Now, I saw 3 surveys and that wasn't cited. That is not saying that I'm telling you what to do today. The good thing is a lot of EMRs are automatically updating your 485 plan of care as you put new orders in. If that's the case, that's fantastic because you're going to be covered both ways. You're going to have the verbal order signed by the physician, but then you have that updated 485 and you're not sending it to the home health physician who signed the 485 unless, and here's the caveat that I'm really waiting for clarification, it's a doc that ordered something that he doesn't know about. Use that same example as the cardiologist with the Coumadin order that Dr. Jones, the PCP, doesn't know about. I would send it to him then because you have to integrate all orders. So that's a very messy answer, breaking it out into little things. I think if your EMR is updating your 45 with orders now, you're great. You're going to have your verbal order and you're going to have an updated 45 that you're not going to get signed every time it is updated, unless I would recommend, this is just Sharon Litwin, if I had Sharon Litwin's agency, if it was a different doc that I was approved to get orders from, if they write an order, I would want to let my home health signing physician know about that. So you have to stay tuned. I told you what one accrediting body in one state said. You know, again, if I was Sharon's home health agency, I would call the state and ask them directly, and I would call my accrediting body and ask them directly, because that's what it's going to be based on. And hopefully, we have the final interpretive guidelines soon. When we get them, I can email Patty with some of this clarification, or we can even do another 90-minute PowerPoint on final interpretive guidelines, because that's going to be very key to how we move forward on these very confusing ones. I know that there were a lot of other questions, but I wanted to take time with that one because it is so confusing. And so, I mean, Patty, we can keep going for a few minutes, or we can, you can email me the questions and I'll email them back to you.
Okay, if you have a couple more minutes, I'm certainly willing to read a few more to you, and then the rest that we don't get to, I can email.
Sure.
Okay, and so then just to follow up on the whole plan of care and updates conversation, another nuance that was presented was, what about patient and or patient representative when changes are made to the plan of care? Is it sufficient for them to speak with the patient representative verbally and let them know and update them on the changes, and then perhaps maybe update a calendar that's in the home, and then document that conversation? Is that sufficient, or would the agency have to present the patient and or representative with an updated copy of the plan of care?
Well, you don't have to give them an updated plan of care, but they do have to have that updated written information. So if wound care is changing, you're going to tell them in writing what that wound care is. If a med's added, you're going to update the med list. Frequency changes, discipline changes, yes, you're going to update that calendar. It doesn't have to be a plan of care. We don't have to put the 485 plan of care with our diagnoses that they won't understand and our interventions that are confusing. You don't have to give them that. You know, meds aren't in lay terms. So you have to give all that written information, and that always has to be updated. And if there is a patient representative, as something changes, you ask the patient if they want their patient representative involved and to hear this and see this right now. If they say yes, then that's what you're going to do. If they say no, you're going to document declined. But the patient for sure needs that written information. And at times, like I said, if the Mrs. Jones and her husband's the caregiver living with her, but the patient representative is 10 miles away and comes over a couple of evenings a week, then you have to find out, should I call them? Should I send them an encrypted email? What should I do if that patient wants them to be involved to that level? Otherwise, having those written instructions in the home would suffice, because then the patient representative will see that and let you know if there's questions, and you will have already taught the patient and had written information there. It's a weak area in home health. This is not an unjustified area. We should have written information that the patient can understand and is always updated in the home, but that is a weak area in home health. So that's something that our industry is going to have to get better at.
Okay, Sharon, let's take just a couple of more. And then these next few questions deal with home health aides and being competencied. So essentially, most attendees want to know if you have a home health aide and you, is it acceptable, number one, to competency them on all the various tasks that are listed over multiple visits? And then just an underlying concern, say, for example, you don't have any patients that you're giving tub baths to. Would it be sufficient if the agency were to competency on them on everything else, and they could allow the aide to see patients, and then if that aide comes across or has a patient that's been assigned to them that requires a tub bath, could the agency then competency that aide prior to sending them out to see that patient on their own? Could they do a competency with that patient to make sure that they are adequately performing tub baths?
That's a very good question, because that is how we have always done it. And that is what makes sense, and that is what is, going to happen, because we're not going to have tub baths. That's going to be very rare. So why would we have to competency on a tub bath prior to an aide going out on their own? I am a little cautious, however, because the one accrediting body is teaching and saying that they are looking for that, because that is what is said. I think, number one, it's not going to be possible. You may have 3 aides working for you, and you're not going to have a tub bath. So if you keep going as you are on an aide that's currently there, it makes sense that what are you going to do, bottom line? Clarification has been asked to CMS over and over on this, and basically, like I said, it's more semantics. Have or instead of and, or have and or. But that is what is being checked on, and I have not received any updates at all on that. Now, I will, what I'm going to do is I'm going to email Mary Carr at NOC, because I did the pre-conference COP classes with her, and we knew that the plan of care and this part of the aid would be the most unclear and confusing thing, and unfortunately the draft IGs did not clear it up a lot. So NOC has put in many comments and had many discussions about CMS, plus from getting information from the accrediting bodies. And if I find out anything else, I will let Patty know. But bottom line, I would be more worried about hiring new aides on without having them competency to all. But for your current aides, again, just as if it was Sharon's home health agency, I would go on as I am. And if a tub bath comes up in the future because a patient bought one of the walk-in tubs, then I would competency the aide at that time.
Okay, Sharon. And then the final question in relation to home health aides. Max is asking, if they subcontract with a company for home health aides, do they still need to have a file for those aides, and would they also need to competency them?
You have to ensure as an agency that all of the aides that are working for you and providing care are competency. As far as, are you going to do the competency, or does the contracted agency do the competency? If you take that competency from the contracting agency, you have to ensure that they completely met all of those regulations about under the direction of an RN, about every section being satisfactory, about everything being checked off and competencied. So you really have to do your due diligence. Now, you would want to have that competency, because how else will you know that they have done this? And then, you're just going to be very sure on visits that you make with those aides that they are competent. So I don't see that there was a specific change to that. What I just said is how it always is supposed to have been done. At this point, I don't see anything different, but I'm also writing, a note that I will forward that on to Mary to see if she's had any clarifications about that either. But do your due diligence on your contractors, especially for aides, but then with all of your contractors, make sure that they're part of the QAPI program, that they are part of that interdisciplinary team, that there is evidence of ongoing documentation of coordination of care, because that's a huge area.
All right. So what we're going to do now is, Sharon, any lingering questions I will email on to you. And then I will just remind everyone that an evaluation of today's event will pop up as you go to exit the event. So we ask that you please complete that, and that if you have anyone listening in at your location, please have them sign the sign-in rosters and then have them fill out the paper version of the evaluation form. And you can fax those back to HCAF at 850-222-9251. And Sharon, I'm just going to turn it over to you for your final thoughts.
Well, first off, number one, you all are very much paying attention and are very engaged in learning these COPs, because those questions were fantastic. Those are the key questions that we still need clarification on, that are way too confusing. And so I think that, you know, like I said, be sure that you talk to whoever your accrediting body is to see what they are surveying today. If you're not accredited, then ACA. And keep posted on HCAF, and, you know, if you're not in NOC, HCAF will hand down the NOC stuff. And hopefully clarifications will come out really soon. And when I get some, I will definitely let Patty know so that she can send it on to all of you. And you can always email me questions as they come up as you're implementing processes or don't understand something at my email here as well. So I know that this was a hard session. I hope that you did get some tips out of it and got some recommendations on what to do in the interim time frame until we have more clarification.
All right. A great big thank you to Sharon and 5-Star Consultant. Sharon, we're so glad you're feeling better. And a thank you to all the attendees for joining us today. And again, we apologize for the inconvenience of having to reschedule, but thankfully you were able to join us today. And we look forward to speaking.
Thank you for that.
Oh, yeah, no problem. And we look forward to speaking to everyone again on Thursday for session 3, which will talk about infection control and QAPI. So until then, everybody have the rest of your day.